I said before the break that we were going to have a slightly different session now. It's kind of one of our keynote sessions. We're calling this our Fireside Chat. So I'm really delighted to have with us here today Dr. Tim Ferris, who is the National Director of Transformation NHS England, the first National Director of Transformation for NHS England. You were previously a non-exec director on the board, and you've been seconded from your previous role as CEO of the Mass General Physicians Organization in Boston, USA. You trained in medicine and public health at Harvard University, and you became a professor there at the Harvard Medical School in 2018. But what's really, I think, great for us today is I said you're in your last week. I was going to say you're in your final week of your secondment, but I think you're actually in your final day. Is that right?
Yes.
So you've got one day. So we are really, really honoured to have you here to be able to capture kind of your thoughts and your reflections on all things to do with data across the NHS. So I'm going to begin, if that's all right, by just asking you, could you tell us a little bit about yourself, the new role, and why were you the perfect person to fill this new position?
Well, I can't say that I was the perfect person to fill the position. So I think, it was a confluence of many factors, but I trained in physics, actually, and was writing programs in Fortran as an undergraduate and graduate student. And so I had a background in data. Then I decided I needed to go into healthcare and went through healthcare. And as soon as I got through my training, almost the very first day when I'm on the wards and in the clinics, I'm thinking, oh my gosh, all of this needs to change. Now that was the early 90s. Everyone knew that it needed to change, and change was happening. And it's been an extraordinary process. I started literally writing on paper, and then increasingly my world became digitized. But the experience of the digitizing my world as a clinician had a strong positive element, and I have to say a strong negative element. And I think it's worth just highlighting those. The strong positive element was I used to I invented, like many doctors do, I invented a way to speak to my patients when I didn't know everything that I should have known about them because the data was unavailable to me because it was paper charts floating around. And I had this, I would say, so how did you understand what the specialist said to you? Like as if I already knew, but I was just testing, right? So that kind of thing is common when you actually don't know the facts. So, fast forward 20 years, and I had 100% of the factual information about my patients in front of me, easily accessible, and it completely changed my ability to deliver great care, like really substantially changed it. But it did something else, and that is EPRs, as one example, are electronic patient records, are not just a filing cabinet, they're also a workflow tool. And suddenly, everyone who uses the same system has to have the same workflow. Well, I can tell you, like clinicians, and I mean clinicians in the broadest sense, that wasn't a welcome thing. Like everyone had to have the same workflow. Not only was it not welcome, but it turned me into a data entry clerk. And more the researchers and the managers were saying, you have to code this, you have to structure this, you have to do that. I'm like, no. And I got to the point, this is well documented, where I was spending 50% of my time documenting.
Wow.
Whereas before, when I was on paper, I would spend 5% of my time documenting. Now, the documentation was much better, which meant that other people with access to the information could use that information for multiple purposes, and we'll come on to that. But it was a huge drag, not just on productivity, but it's also a huge drag on work-life satisfaction. Because honestly, I would have to go home, put my kids to bed, and then stay up several hours to finish the notes from that day. And you can do that for a couple of years, you can do it maybe for a little, but doing that 20 years, it's very unpleasant.
Yeah.
And you start thinking, why? Why am I doing this? And so the current sort of dissatisfaction in medicine is in part being driven by what we've asked them to do to become data entry clerks.
That's really interesting, because I don't think that element has come up yet in all the conversations this morning, which is we want more data, we want good data, but that comes with it then the kind of bureaucracy around how you manage and structure and collect all of that data, and getting that balance right, or who does that. It's very tricky kind of areas. So we might come into that a bit more, but I do want to ask, before you leave your current post, because obviously you trained in America, you come over to the UK. What surprised you most? You've had 2 years now in this post. What surprised? I bet there's lots of things that surprised you, but when it comes to data and the use of data across the NHS in England, what really surprised you the most?
How long do we have? I was surprised at the extent to which the front line wasn't digitized. Now, we're very close to finishing, by the end of this calendar year, 100% of the acutes that are not on a medical will be in procurement for an EPR. That's great. We sort of put that to bed. I did notice in the press this morning, Jeremy Hunt was quoted for a speech in, I think, 2015, saying we would be paperless by 2017. I'm sure I got the dates not quite right, but there was something else that I loved about that quote, which is it's absolutely the right aspiration. But there's another term that I learned since I've come here, which is called optimism bias. And I hadn't heard that term before here. And I thought, well, we should have an optimism bias, right? I mean, how do you achieve anything if you don't have an optimism bias? It's interesting how that gets turned on its head in the political sphere and becomes actually becomes a cudgel. So that's one thing. Is the basic infrastructure throughout the NHS? It needs significant work. It's patchy.
Yeah.
The second thing I would say is the word national in National Health Service is an interesting description of what is like extraordinarily autonomous and siloed organizations, like literally hundreds and hundreds of them, each with their own information governance leads, right? And that means each with their own decision making. Now, if the decision making was clear, if the rules were clear, then I don't suppose that would pose a problem. But because actually IG rules have lots of ambiguity in them, and then you have 1,000 plus people making decisions, what you end up with is really inconsistent decision making throughout the NHS, and therefore patchy access for technologies that you're trying to adopt to get access and implement it. And so people often wonder about some of the issues associated with the speed of adoption of innovation, digital technology within the NHS. And I would say, well, one of the main reasons is actually lack of clarity around and a real high degree of variability in decision making around information governance.
Do you think some of that...
that was only the first two, by the way.
Oh, sorry.
No.
Well,
I'm teasing.
I'm going to jump, because we heard in sessions this morning that sometimes that inability to share data across the public sector and across different bits of even of the civil service is because officials might not know what data they can share, what the legislation is. Do you think that's even worse in the NHS, because you're dealing with such sensitive data that actually people are scared, maybe across two different hospital trusts, for example, to share data?
I think almost every government agency is working with sensitive data. I would say two things about it. How personal the data is, like it's not your address and phone number. It's all kinds of things that most people would not, and it should not be shared. The scale of the data challenge is pretty amazing. So I did a back of the envelope calculation. I don't know if this is true. Someone else can figure this out. But I was trying to figure out, so it looks like the NHS collects the same amount of data in 1 year on the population of this country as was recorded throughout all human history up to the year 1985.
Wow.
That is the scale at which, and think about just one MRI scan or one CT scan, one genome. We're doing millions of those, right, every year.
Yeah.
So the scale of the data challenge is remarkable. What was your question?
Well, I'm going to come on to something else. I'm going to come on to I can't remember what my question was now, but the question, I want to come back to optimism bias, because you mentioned optimism bias, but I want to come on to your optimism, because we have spent quite a lot of time today talking about barriers and obstacles and challenges. Before you leave, I want to ask you, how far do you think we can go if we use data well, if we implement all of these new technologies? What difference could that make for our health service?
So I'm going to repeat something that's been said really frequently since the middle of the pandemic to now, and then hopefully build on a little bit, which is getting through the pandemic was, if there was, the list of top 10 things we learned, very near the top of that list is when we are all aligned around what it is we need to do, data can do amazing things for the health of the population. Now, what that took was a COPI notice, like alignment from number 10, Cabinet Office, Treasury, DH, NHS, all the way down to getting your jab around the corner here, which actually I got my jab right around the corner here, one of my jabs. And that was one really narrow vertical, right? Now say, okay, so let's say, I'm a hypothesis. The NHS has a capacity problem, small capacity problem, around much more than the delivery of COVID services. Is that?
That's a fair.
It's not a stretch. It's
No,
a fair
that's a fair
statement.
thing to say.
And so it's impossible to think that greater use of data won't be part of the solution to that capacity problem. I absolutely commend the government and the NHS for the workforce plan. Absolutely essential. We needed it. But honestly, you look at those numbers that need to be hired into the NHS to provide healthcare services for the next 25 years. That is a big challenge. It's a significant increase in the workforce that's in healthcare. It's impossible to imagine that data and technology won't be needed in addition to that workforce to deliver the ever-increasing demands in healthcare. And we don't have, right now, things are getting better. You asked at the beginning about the Transformation Directorate. The Transformation Directorate has done a phenomenal thing. It took 4 different organizations and put them all together into one. I can't having lived through that process, it has dramatically simplified. So rather than one ALB asking another ALB, negotiating a contract, signing the contract, holding to account for the contract and KPIs, no. The way it works is I make a phone call to someone who works for me, and we say, okay, new project, we got to get this done. Huge amounts of bureaucracy and tension around, oh, that wasn't in the contract, we didn't do that. How do you do agile development? You guys all know about agile. How do you do agile development across a contract? It's really hard.
Yeah.
And so bringing all those organizations together so that we are aligned was a big part of what we've done the past couple of years. That will set us up well, but we're not quite there yet. We still have lack of clarity around some of the IG issues. I will just say that we actually don't have access to some of the really critical pieces of data that are necessary to manage the delivery of healthcare and conduct research on the next cures. So we haven't, everyone sees the promise that the UK has for using its data assets for the transformation of care. We're on the right journey. I think we're on the right path. But we need to do something, if you don't mind me saying this. in the past, when we sit around, particularly in government, where we are really, really good at assessing the risk of change, what I think we need is when we sit around in those rooms and we assess the risks of change, and sometimes those conversations turn into catastrophization, if that's a word, like, oh, this could happen, or oh, that could happen. What I am most focused on is that the status quo is not okay. And in fact, the risks of the status quo are significantly greater than the risks of change. Now, you have to, careful. We were talking about healthcare here. It's people's lives. Yes, I get that. But again, the pandemic showed us that if we are really focused and monitoring change as it's happened, we can redirect. I'll give you, the most concise example that I know of is the way data was used to make sure different segments of the population were getting vaccinated, right? Because we could tell, and talk about the importance of real-time data, we could tell on a day-to-day basis which subgroups of patients weren't getting vaccinated, and increasingly segment the population. Okay, what's the strategy in this neighborhood? The current strategy isn't working, we need a new strategy. That allows you to pivot and go after those processes. But it requires extraordinary access and processing of very large amounts of data. The technical aspects of doing that are not a challenge anymore. It's simply not a challenge. I was doing physics experiments when I was really concerned. I had to be very concerned about how much memory and processing time, and I had to wait for processing time, right? That is not an issue anymore. The issues now are political, workflow, legal IG, oversight. We have got to come together around the set of issues that will enable what everyone sees in front of us as a huge opportunity. But it's been really difficult to, we're making progress, but we have a long way to go.
So I want to squeeze in one question from the audience, but my final question to you before I do that, then, it sounds like everything you're saying there is there's this huge potential, huge opportunities, but you're still handing over a big challenge to your successor. What's the one tip you would give to your successor when it comes to maybe looking at the workforce that they're going to be leading?
Yeah.
How's that workforce going to change with all of these new data and digital technologies?
Well, one of my best day of every week is Friday, because every Friday I go somewhere in this country and spend time with an A&E physician watching them work, or in an ITU or labor and delivery. And a couple of Fridays ago, I went actually to UCL and saw a group of undergraduates who are partnering, undergraduate computer science majors, partnering with the NHS, Great Ormond Street and other organizations, solving problems that clinicians and managers had on the ground. And I was so impressed at what a 17-year-old can do in the right mentored setting with the right exposure to the right questions and the right access to data. And it really gave me hope. Like, oh my gosh, some of them were solving problems that we're doing huge commercial, endeavors around. And yes, there's cyber concerns we have to be worried about and everything. But that workforce that wants to contribute to the solutions of our society's biggest problems is out there.
Yeah.
And we've got to unlock it. And there are little places where it is being unlocked, but that needs more water,
Nurturing.
Sunlight.
Yeah.
Yes, exactly.
Brilliant. Thank you so much. Really sorry, I know your time is so tight, and we've only probably got time for one question. Does anybody have a question to put to Tim? Yes, we've got the lady there. Sorry, Jack, we've got one question behind.
Hello.
Hi.
I hope I'm not putting you on the spot trying to get you to answer this question. So if you don't know the answer, please don't worry. It's about datexes. So
About what?
Datexes. So datexes are basically incident forms to all intents and purposes. So on the front line at wards, our nurses are spending a lot of time filling in responses to these particular pieces of paper, to all intents and purposes. Because of that data collection is obviously taking away from that
Yeah.
direct patient care.
Yeah.
So clearly there is a cost element, and I don't necessarily mean from a financial perspective, but I wondered what sort of changes are looking to be made in the future
Yeah.
to enable less of that to happen.
Yeah.
I think they're
Yep,
cutting us off
I
because
got
of
it.
time. So
I
this
got
comes
it.
back to what
So
you were saying.
I'm
Yeah.
so glad you asked that question. I'm going to do what I don't know, clever responders do, which is to turn that into the question I wanted you to ask. But I think I'm going to answer your question, and that is, I said at the beginning that technology was a huge problem. Technology is also going to be the solution, because everything that we've seen in the last year with AI and large language models, I am absolutely convinced, and I've seen it for myself, the documentation issues that are a huge burden, the burden to those nurses, that is just one, I'm sorry to say it like this, but that is one small of a massive documentation problem, which is a huge drag on the productivity of the service, like a 20, 30, 40% drag. I know of nothing in the 10-year horizon that will add to the productivity of our clinicians as ambient documentation. So ambient documentation means, the brief of this is, I'm sure you've heard this, so apologies, but when an airline pilot leaves a plane, everything that she just did from entering the plane to leaving the plane is documented. And she documents nothing. That is because the environment around her has been built to do the documentation, and she just does. That is possible in healthcare, and I've seen it, and it is stunning what is possible. So you just do your work, and the environment that you're in does the documentation. Now, he says, technically, that's done, okay? What is necessary technically to produce that is available. It'll be available commercially very shortly, but it's already available, and I've already seen it happening, and I've used it myself. The challenge is, again, it's a big change in our workflows, and here's maybe an even bigger problem, which is, do we have confidence that our voice interactions, which become stored in bits and bytes, are going to be, and that's going to generate massive increases in data, right? So we're going to have to develop workflows that give us confidence that, okay, so the voice part, as soon as it's turned into text, is immediately deleted, and then you've got a large language model taking that, what is essentially a transcript, and turning that into the kind of structured documentation that you need. That is all doable. If I were to advise, say, I don't know, the Prime Minister, for example, on what the biggest bet should be, I think it should be in ambient documentation. If I were to say, what's the number one thing that'll bring a lift to the productivity of a service that is challenged in its capacity? Thank you for asking that question.
Fantastic. What a note to end on. I hadn't heard of ambient documentation, but it sounds like it could change fundamentally so much. Thank you so much, Tim. I'm really sorry that was all the time that we had,
Yeah.
and it's gone so
My
quickly. We could
pleasure.
speak to you all afternoon. Thank you so much. Thank you for what you've done over the last 2 years, and I
you.
wish you all the best
Thank you very
in what
much.
you go on to
That was
do.
great.
Thank you
Thank
so much, Tim.
I take my
Yeah,
tea.
Brilliant. Thank you.